Okay, we're live. Hi, this is Elliot Fishman, and this is December 23rd. We're reaching the end of the year, but we're still live and well doing these Facebook podcasts. This one I have, so first, let me just say, wish everybody a happy and healthy New Year and happy holidays if we don't speak with you. I know we're 2 days before Christmas, so happy Christmas to those who celebrate Christmas and happy whatever to those who just are happy they're off from work. Now, let me speak to you a little bit about postpartum CT. It does seem that we are getting more CT scans now in postpartum patients. It's often due looking for complications. C-sections probably occur in 1/3 of U.S. live births, so they are more frequent, and so most of the complications we see or suspect are in patients post C-section. There was a good article just published by Zacharias in Abdominal Radiology, and let me tell you about some of the things that I read in the article and that I think would be helpful. So they do comment that C-sections are common, 1/3 of live births. In the acute post-op setting, it can be difficult to distinguish changes of the expected recovery of the uterus from those of complications. So it's our job as radiologists to understand the post-op appearance and recognize that there are certain things you're going to see post-op: small hematomas, peri-incisional edema, but we need to be able to recognize complications. Commonly seen after C-section include complications like subfascial and bladder flap hematomas, uterine dehiscence or rupture, endometritis, septic thrombophlebitis, retained products of conception, and vascular complications such as uterine artery pseudoaneurysm, AV fistula, and ovarian vein thrombosis. One of the things you need to do when you scan a patient, you may need a single or a dual phase imaging depending what you're thinking about, to look for all of those complications. You need to scan from diaphragm to symphysis to make sure you cover everything in between. Now, we also talk about delayed complications, which include scars, C-section ectopic pregnancies, endometriosis at surgical sites, PID, bowel obstruction, and some of the complications are manifested in the next pregnancy if the patient gets pregnant again. Now, the article makes the point that you could divide things into 3 stages: early, which is 1 week postpartum; middle, 1 to 2 weeks; and late stage, over 2 weeks. The early stage involves myometrial contraction and rapid involution, up to 50% decrease in uterine size within 48 hours. And imaging at this stage demonstrates debris excuse me, often with air in the endometrial canal. Middle stage, a more gradual involution, decreasing myometrial vascularity. And in the late stage, myometrial vascularity continues to decrease, but you want to look for complications like venous thrombosis. Imaging typically shows solid and air components resolving by 3 weeks, sometimes with a small amount of residual fluid in the endometrial cavity. Now, obviously, how fast the air and fluid resolves truly depends on how much there is to begin with. If there's more in the beginning, then it's more likely for things to take a while longer. We talk about hematomas and we talk about the location from the outside in: subcutaneous, rectus, subfascial, bladder flap, with pelvic or retroperitoneal extension. Often there are hematomas in more than one site. Injury to the inferior epigastric arteries can cause significant rectus bleeding and may even need embolization. Subfascial hematomas are characterized by fluid in the prevesical space, and this type of hematoma carries a higher risk of blood loss due to potential extension into the retroperitoneum. Uterine rupture, which is rare, refers to the breakdown of all three layers with direct communication between the uterine and abdominal cavities. More complex hematomas should raise suspicion for rupture. CT is the preferred modality for evaluation of uterine rupture, though ultrasound often can be done first. So again, it is one of the important complications. Endometritis is the most common postpartum infection, with C-section being the highest risk. The way you make the diagnosis: patient's history, fever, abnormal vaginal discharge, uterine tenderness. The CT signs are relatively non-specific, but an enlarged uterus with fluid and debris, endometrial thickening, and again that hyperenhancement. Now you have to be careful if not treated correctly. Endometritis can progress to salpingitis and pyometria. We talk about vascular complications. Ovarian vein thrombosis is rare but can occur. It can be complicated by septic thrombophlebitis. On CT, we can see very nicely the presence of ovarian vein thrombosis. So you want to look carefully at the parametrial regions. You also want to look at the IVC. And in some patients who are short of breath, we're not only doing the abdomen, but we're doing the chest to make sure patients don't have PE. PE is one of the important complications in the postpartum patient. We talk about abdominal wall endometriosis, which occurs in less than 1% of patients along the scar of the C-section, but it is something to consider. And again, as I mentioned, some of the complications like endometriosis may be problematic the second time the patient becomes pregnant. And again, it's a tough diagnosis, so it's just something very important to look at. So you can think about it then, when we do a postpartum patient, we want to look for complications. We want to look carefully at the uterus, the parametrial regions, the vessels, both arterial and venous. We want to look at the bladder. We want to look at the abdominal wall, the subcutaneous, the rectus, the subfascial regions. You want to look at all of those things. Axial and coronal become very important. Again, single phase can be done, but in many cases you need dual phase imaging because of everything you're looking at. So with that, go read that article. It's worthwhile reading. They have some very nice images. And if not, wish everybody a great day. Take care now, and happy holiday.